Thank you for a great introduction. And as you mentioned, so my name is Sungchul Park and from Korea University, obviously in South Korea. And today I'm going to talk about the effect of Medicare coverage, implication for value-based care, and social determinants of health. So as he mentioned, so I got my PhD degree from the University of Washington, I think 6-7 years ago. And then after graduation, I worked as at Drexel University in Philly, and then COVID happened, and then I decided to go back to my country more for personal reasons, like family issue, and then I'm currently working at Korea University, and recently I got promoted. So yeah, and then so before talking about my today's talk, I wanna just mention my 3 research interests. The first one is I'm curious about how to improve healthcare system, how to improve payment and delivery system, but goal is how to improve the value of care. And then second, we care about we are always thinking about how to improve health outcomes, right? But we know that health outcomes may be affected by healthcare system, but as well as other non-healthcare system, right? So in that sense, I'm also interested in understanding how to integrating social determinants of health into healthcare settings, so that we can maximize the benefit. I mean, how to improve health outcomes. And then finally, I'm also interested in understanding how to employ some recent methodologies, for example, causal inference and machine learning, big data, so that I can answer some interesting research questions. So for today's talk, today's talk mainly focused on Medicare coverage. So I start with simple background, and I will be talking about some what kind of methodology I used to estimate the effects. And then so today I'm going to share findings from my research. And I'm not sure, but if I have time, so I'm happy to introduce my recent work in the context of South Korea, but it looks like we may not have enough time. So for today's talk, background, so Medicare is one of the largest public health insurance program in the United States, and Medicare covers about 60 million older or disabled adults in this country. And we know that some people may receive Medicare coverage before age 65, but the majority can receive this coverage when they turn into 65, right? And there is ample evidence showing that Medicare coverage improved access to care, so that healthcare utilization increased, right? So that's lots of people, they experience improvements in health outcomes. And also Medicare coverage decreased out-of-pocket spending, right? Because Medicare coverage is relatively generous. So that's people experience lower financial burden of care after they obtain Medicare coverage. So that's these findings suggest that Medicare plays a critical role in improving financial health and financial security for the elderly population. So this is what is known, but I think there are some important research questions remain unanswered. So today I'm going to talk about what they are. So today I'm going to talk about 3 findings, findings from 3 research. The first one is, in the previous slide, I showed that Medicare coverage increased healthcare utilization, right? But we don't know that whether the increase in healthcare utilization may be driven by high value care or low value care. High value care means when we receive that kind of care, we may obtain benefit, we may experience improvement in health outcomes. But for low value care, may not improve our health outcomes. So just using healthcare services without any clinical benefit, right? So in the first research question, I try to examine that answer. And then in the second research, so in the previous slide, I showed that I mentioned that Medicare coverage improve financial security, right? But but I think this may has some kind of like spillover effects on non-healthcare social determinant of health. For example, like food insecurity, because people who are experiencing like food insecurity have limited resources, right? So they have to figure out how to allocate their limited resources, receiving healthcare or purchasing food, right? So if Medicare coverage improve financial security, then probably now people have more money, right? So that they can spend the money on like food purchase. And then the last research that I'm talking about today is mental health. So I think the prevalence of mental illness is increasing globally, but research showed that only 50% of this population receive proper healthcare utilization. So, but in the previous slide, I mentioned that Medicare coverage is usually generous. So that probably we thought after obtaining Medicare coverage, mental health problem may be relieved because improve access to mental health services. And in this research, I examined whether that is true or not.
Yeah,
Sure.
I don't know if I can interrupt or not, but yeah.
That's what
So yeah, from the industry, the rumor says, not as a scientific study, a lot of people wait till they reach to a 65. Because usually it costs a lot of money to get a lot of surgeries, for example, cataract surgery and a lot of surgeries, in elective ones especially. They want to wait till they reach to 65 and they just get it as soon as they're eligible to Medicare. The rumor. In the end, we don't know how to verify it. So yeah, and yeah, there are a lot of kind of things related to Medicare coverage because a lot of times US actually this Medicare system is, as you said, starting from the 65, kicked in at 65, and before 65, almost kind of you don't have either you have a very high deductible coverage if you're already retired, or kind of maybe almost no coverage from the Medicaid. Yeah.
And I think one study examined that is true or not. And I think that kind of phenomenon can be called like pent-up demand. And that study found that there's no evidence of like pent-up demand. So people do not wait until they turn into like 65. So I'm not sure, but the paper says that it's just rumor.
Yeah.
So in the previous slide, like the goal is to estimate the effect of Medicare coverage, effect of Medicare eligibility or coverage. So here, so I know like you may be familiar with like causal inference, but just in case, let me explain one more time. So probably so in this study, like what I wanna estimate is the causal effect, not just like simple association. So probably what is association and what is causal effect? So association, let's say we want to know the relationship between A and Y. Then under the association, probably A may be affecting Y and Y may be affecting A. And there may be third factor, X. And X may be affecting A and Y at the same time, right? But what we want to know is whether the treatment is affecting the outcome Y, right? So in this situation, we are able to control the third factor X and the reverse causality Y from A, right? So then how can we estimate the causal impacts? I think the ideal setting is RCT, right? So when people are randomly assigned into the control group and the treatment group, then random assignment means that people in the treatment group and people in the control group, their sample characteristics on average should be exactly the same, right? So if we find a difference in outcomes, then the outcome may be driven by the treatment, right? Because people in the treatment group, control group, their sample characteristics are similar. So then that means we are able to control the third factor X. But conducting RCT is very costly, right? So ultimately, what we can do is we are able to use some secondary data set that were already collected, right? But the problem is that in this data, when people receive a treatment, that might not be at random, right? People who wanna receive treatment get treatment, and people who don't wanna get the treatment didn't get the treatment, right? So there may be some selection issue. But if we are able to change this situation from non-random assignment to random assignments, right? That means people who receive the treatment and people who did not receive the treatment. If we are able to change to random assignments, then even though we are using some observational study design, then we might be able to estimate causal effects, not just association. And this kind of setting can be called like quasi experimental study design. And there are multiple study design, but today I want to focus on our regression discontinuity. So what is this one? So if you take a look at this figure, so x-axis shows age, and here age 65 and lower than 65 and greater than 65, right? And in this setting, people are able to obtain Medicare coverage when they turn into 65, right? And here y-axis shows the percent of people who obtain Medicare coverage. So as I mentioned, even though before 65, some people can get Medicare coverage because of disability status, right? So here there are some people. But when they turn into 65, now by law, they are able to apply for Medicare coverage. So that there is large increase, right? So this is called like discontinuity. So then the outcome of interest, suppose that is better health, right? So in this setting, we want to know whether the effect of Medicare coverage on health status. Then, because of the Medicare coverage here, the proportion of people who report better health may be increasing, right? But here we may have some question. So to argue that, so this improvement is mainly driven by the Medicare coverage. What do we have to find? So going back to this slide. So here, right, we have to control for X. So that means people who in this group and people who in this group, their sample characteristics should be similar to each other, right? So there are several assumptions for this method, but one of the most important assumptions that we have to examine is below 65, above 65, their sample characteristics should be similar to each other, right? So it is okay to change, but what we have to see is there is no discontinuity at age 65 except for the treatments. So in this case, Medicare coverage. So for example, race, ethnicity, or education income can be changed, but we should not expect discontinuity for these variables. Then, it is reasonable, right? People, for example, like 64, 66, we should not expect like a drastic change, right? So when we conduct like regression discontinuity, so for example, people 40, like 80, if we include this population, their sample characteristics may be substantially different, right? So that we should limit our sample to people within a narrow bandwidth, so around like 65. So for my research, I used the medical expenditure panel survey. So which includes kind of provides like nationally representative sample. And then this data provides lots of like detailed information on like health status, healthcare expenditure, utilization. And for this study, I limit my sample to people for age 59 to, I think this is type, yeah. So 71. And then I exclude people who are age 65 because some people may be affected by, some people may obtain Medicare coverage like April, others like December. So probably including this population may produce some biased estimates. So we decided to exclude this population. And for outcomes, I will explain later. And for each study, I slightly change the sample, but I will explain that later. So for the so when you conduct like whenever you conduct like regression discontinuity, so first we have to show whether there is a change in particular, like so in this setting, first we have to examine whether there was a like change in health insurance coverage, and then later we have to check whether there is a change in the outcome of interest. And we can examine like in two ways. The first one is visual examination. So this is the outcome here, and then this is age. So as I mentioned, so people can obtain Medicare coverage when they turn to 65. So we have to observe this kind of pattern. So at 65, large increase. But for Medicaid coverage, we should not expect any change at age 65. So we do not expect, we do not observe any change there, right? And then after looking at this result, like visually, then now we can conduct a regression model. Then this is the result. So this means that after adjusting for like sample characteristics, we want to estimate the magnitudes of the effects. So then, so the effect is 81.5 percentage points. So this means that so after age 65, the Medicare coverage rates increased by 81.5 percentage points. But for Medicaid coverage, the magnitude of the change was very marginal and not statistically significant. So for each study that I conduct, so I first perform this kind of like visual examination and then conduct like statistical tests. But for the final results, I will be showing the results something like this. And then from now on, I'm going to talk about the results more specifically. So the first results of the first study focused on like value-based care. So the research question that I ask is, does Medicare eligibility at age 65 lead to change in the use of high and low value care? So this is because, so you know, the improving the value of care has been an origin goal in the States over probably 2 decades, right? So CMS has tried to improve, like adopt multiple like payment model, for example, like ACO or like bond payments. Also several initiatives, for example, like Choosing Wisely, has tried to reduce the use of like low value care. So then this may affect how practitioners produce like deliver care. So I examine these research questions using the maps, and here's the results. So this slide shows the use of high value care. And I include 3 different types of high value care. The first one is cancer screening, and second, diagnostic and preventive testing, and the last one is diabetes care. Sure.
Could you actually give a bit more context on the how you classify high value care and low value care? So the high value care may be more the preventative and the kind of long-term high value, or kind of how would you kind of give us some examples on what is a high value care and low value?
Sure. Yeah. So high value care. So I define these services based on like previous studies. But high value care means some services that produce more like clinically meaningful like benefits. And low value care may not, even though we receive services, but these services may not produce like clinical meaningful benefit, or sometimes produce clinical harms.
Like some aesthetic surgeries?
It may improve, right? So, and probably you may want to take a look at here. So this is the final results. So as you can see, some statistical significant changes were only observed in cholesterol measurements and influenza vaccine, right? And for other 6 high-value services, we did not find any changes. And then the next slide shows the use of low-value care here. And low-value care, we include, I think, 3 types of low-value care. The first one is antibiotic use, second medications, and then the last one is imaging. So it looks like very simple, but I did find each service is very challenging because first we have to figure out like who should be the right person, right? For example, MRI CT for back pain. So first we define people who experience back pain based on their claims data, and then identify whether this population, each person received MRI CT or not. So for each outcome, the sample population may be different.
So the assumption is for those population, MRI is not quite deep.
Did not work well.
Yeah,
It's
yeah.
still like kind of clinical evidence.
Yeah, clinical evidence. Yeah.
Yes, I just want to make sure I'm interpreting it correctly. So the finding here is that Medicare eligibility increased the uptake of the low value care item of radiograph for back pain by 4.6%. Is that how you would interpret this?
This one?
Yeah.
Yes.
So then Eubin's point is, I mean, initial point is to some extent supported, not for all of these, but for certain services. Is it, I just want to make sure I'm,
The demand goes up.
that people are potentially deferring radiograph for back pain until they're eligible for Medicare? Like, could that be what we're seeing here? That certain, so antibiotic use and radiograph for back pain are certain services that are maybe deemed low value, but Medicare is promoting them, if you will. Is that a fair way of interpreting the data?
I don't think it's a promoting. It's actually more of the they have a better access.
Yeah.
Oh, no, Medicare is not choosing to, Medicare access. What I'm saying is as a consequence, of Medicare is what I'm saying, like an unintended consequence.
Yeah.
People are self-selecting, like, so I'm just curious, because from the beginning, when Eubin made his point, I was thinking, oh yeah, that seems to be something that could happen, and it seems like your data are potentially showing partial support for that. So I would just want to make sure I'm interpreting it correctly.
Yeah, so I think based on these results, so Medicare coverage, like after having Medicare coverage, people now have like improved access to care, right? But I think the Medicare program is not designed to improve value of care. So when Medicare improves access to care, it is not designed to like account for like oh, these services is high value or low value, just improving access to care. So that's the reason why we found increase in high value care, some services in the previous slide, and some services in low value care. So again, for the use of low value care, only 2 services here, antibiotics for acute upper respiratory infection and radiograph for back pain. And for other services, we did not find any statistical changes. Sure, sorry.
Since I know you are short in time, this is the first aim, but like the ends keep changing for all these different outcomes.
Right.
And so what is happening? And the other one is it the norm in your space to adjust for multiple comparisons, like multiple hypothesis testing? So because many of these are like borderline significant from an observational study, so you typically adjust for multiple comparisons.
Yeah, so because the sample size is different, because for this example, like we limit people who experience depression, and for this one, people who experience like back pain. So there's the reason why the sample size is different. And then because we did not find any significance here in the majority of outcomes, so we did not conduct like multiple testing.
Correcting for multiple testing, like so as in like are you falsely discovering associations because you're doing many tests?
Right. But yeah. I think there is great points. But as you can see, we have in total like 7 outcomes, but only 2 outcomes were found statistically significant, right? So then like we thought like we don't need to like conduct like multiple testing.
It's a big discussion, but we don't want to. I think I'll just add, I think the concern is they're borderline significant, so let's say you had adjusted for multiple comparisons, 0.1 would have caught, the bottom one.
Yeah.
I'm fixated on radiograph for back pain.
Sure.
So
Yeah, I totally...
it would have crossed into statistically insignificant if you had corrected. So I think it's just a point of interpretation.
I think that is a good point, but I think the overarching so let me move to the next slide.
Sure,
yeah. So but when I wrote this paper, so the key takeaway is that even though we found some increase in use of like some high and low value care, but we found the majority of high and low value care services did not change. So then we decided not to like conduct like the kind of testing, because this is not our point, this is our point. So taken together, we found that our results suggest that Medicare is not fully geared toward bed-based care. So the policymaker now think about like how to improve the Medicare system, the design, so that providers can provide like more like high value care and not to provide low value care.
I'm so sorry, but
no, it's fine.
Could you please go back 2 slides? I just want to see your high value care slide.
Sure.
1 second. So this is the thing is I think what you see in the low value care makes sense. We want to see that, right? We don't want to see Medicare encouraging, it's not its intention, but encouraging the uptake of low value. But when I look here, I don't know if this is about like high value care is already high before Medicare.
Right.
So I think that's what we want. These are services that the population, clinicians, everyone is maybe understands that there is value. So maybe it's not Medicare is broken in this regard. It's just another way of interpreting. I'm just looking at, as someone who works in cardiometabolic disease, I was looking at that. I wanted to see the blood pressure and cholesterol and the A1C measurements, right? So it seems like, I guess we could increase it further, but it's already pretty good. Like it's high.
Right.
That's all. Anyway.
Yeah.
I wanted to see your numbers to see if that was that interpretation was gonna follow from the data or not.
Yeah, I think that is a great point. So we already discussed in the paper. So this paper was already published.
Yeah.
So
sure.
there's a reason why. So we were trying to understand what is happening because the changes, the increase in the use of high value care was kind of limited, right? So that the argument that you just made is one explanation because the use of high value care might be just like already high. So there may be a limited room for improvement.
So I know we need to move on, but yeah, blood pressure measurement, is it actually the measurement for whether they take the blood pressure at the clinics, or is it the blood pressure under control of the hypertension patients?
Whether they receive measurement or not.
Yeah. So yeah, I think when you actually look at the blood pressure under control, I think the numbers actually are not that high for both ends. So for example, at the HbA1c, if you actually look at the not just the actually whether they take the HbA1c test or not, when you actually look at the HbA1c under control, I don't think there is a much difference between the before Medicare and after Medicare either. Yeah. Although that's difficult to figure out from the claims data only because you need the lab data.
Yeah.
But yeah, from the industry point of view, which actually have all lines of businesses on my hand. So yeah, that's kind of how I see it. It doesn't quite change the outcome measures actually difficult to change. But taking these things, also because maybe incentivized by the employer plan. So because the employer benefit plan also incentivized to take those tests.
Right.
Yeah. So they are kind of they are already kind of gearing for before actually getting into the Medicare. Yeah. But the outcome is also very totally different.
Right.
Yeah. I think we can move on.
But thank you, really, I mean,
Yeah.
you know you're speaking on an interesting topic, we get a lot of questions.
And then in the second questions, the question that I wanna try to answer is, does Medicare eligibility at age 65, have spillover effects on other health-related social needs, for example, social insecurity? Because as I mentioned at the beginning of today's talk, so when people obtain Medicare coverage, right, Medicare coverage can help to decrease their out-of-pocket spending, right? So that this may improve their financial security. Then now people can spend more on non-healthcare factor, for example, food purchase. So that this may lead to improvement in food insecurity. So in this study, we try to examine whether this is true or not. And only one table for these results. So here there are multiple outcomes. The first one is health insurance. And then second, affordability of care using 4 different measures. And then the last one is food insecurity, low or very low. And here we observe changes in health insurance, for example, Medicare coverage. After 65, the take-up rates increased by about 80 percentage points. And then for affordability of care measures, so here we found decrease, and except for this third measure, we found statistically significant decreases. And you may argue that this 1.4 percentage points, 2.6 percentage points, or 1.7 percentage points might be too small. So I tried to estimate expressed in relative terms. And then we found that the change, the amount was about 30% and 27%, 30% and 26%. So when you take a look at here, even though it looks like very marginal, but the effects might be substantial actually. And then we found that Medicare coverage improves financial security, right? And then now we want to take a look at how the impacts on food insecurity. And when you take a look at the low food insecurity, low food security, Medicare coverage decrease low food security by 3.3 percentage points. And this was about 30% decrease. And then we also examined the impacts on very low food security. And in terms of the direction, it's decreasing, but not statistically significant.
Essentially,
Sure.
just like out of my lack of awareness, but other things may also happen day 65, like retirement, which might lead you to like reduce your expenditure on things like travel, like commute to work, or maybe some of your savings might actually actualize, like something like an IRA might be open. So how do you account for those kind of things?
Yeah, so I think that is a great point. So probably like, lots of people are retired around like 65, right? This may affect like income, right? So in the model, we try to adjust for these factors, for example, like employment status, income status. And actually, after even adjusting for these factors, we found this robust, statistical results.
I think there are plenty of people who retire at the 50s. So what you're saying is that if you track all those unemployed all along the way, still it goes down.
Yeah,
Oh,
yeah. But as you mentioned, so there are maybe some factors that we cannot measure based on our data. So obviously it's not possible to like rule out all possibilities, but we were trying to do our best to show our results may be robust. Yeah. And then, so the key takeaway from this research is that Medicare coverage decreased both the financial burden of medical care and food insecurity. But when you take a look at the very low food security, no change. So what does it mean? So I think our finding provides new insights into the way in which Medicare coverage can impact health by addressing both healthcare and social determinants of health. But we found that the very low food insecurity was not affected. So to improve more severe form of food insecurity, I think additional intervention may be needed. And then the last research that I want to show today is mental health. So this is kind of like ongoing work. And the previous two studies were already published. And in this research, what we are trying to answer is Medicare eligibility at age 65 leads to change in mental health care services among adults with severe mental illness. So unfortunately, Medicare does not cover some important mental health services. And you may heard about that. People may experience limited access to psychiatrists, especially under the Medicare program. And I'm not sure whether we are familiar with like Medicare coverage, but Medicare coverage has some kind of like mental like healthcare provider networks. And compared to traditional Medicare, like based on fee-for-service programs, Medicare Advantage program may restrict access to specialists using this kind of like network provided networks. Sure.
I need to study history a little bit more, but just from someone who is in the ground, somehow a lot of the psychiatric facility fees are covered by Medicaid, not the Medicare. I don't know why. So I think a lot of our behavioral health conditions seem to be more on the Medicaid pocket than the Medicare. I wonder it's also related to the SDOH to some degree. And I don't want to be a conspiracy theory. The reason Medicare Advantage has a limited network for the mental health is maybe to weed out.
You mean
Yeah.
to discourage?
Yeah, but that's the rumor. Yeah.
Yeah, so
Yeah.
I think like the price
Yeah.
are relatively lower.
Yeah,
under the
that's true.
Medicare.
Yeah, that's much ROI, not much ROI.
Right.
Yeah.
So providers decide to like kind of like opt out from the Medicare.
Mhm.
Yeah, so I think that maybe some like explanations.
Mm.
So I think so let me share the results what we found here. So here I include 3 different types of like outcomes. So here the first one is health insurance coverage usually and access to mental health services, and the last one is healthcare utilization. So here in this study I lead sample to people who experience like serious mental illness based on survey measurements. And then, so the Medicare coverage after 65, their Medicare coverage take-up rate was increased about like 55 percentage points. And then in terms of mental health services, so outpatient mental health visit decreased by 4.1 percentage points. And specialist mental health visits did not change statistically significant, but the direction is decreasing. And medication use utilization also decreased by about 5 percentage points, right? And then one more interesting theme is that because this population may not receive advanced mental health services, so here, as you can see, ER visit increased by 9.7 percentage points.
And here in this one, provider visits is any encountered or like any provider visit, inpatient, outpatient, or what is provider visits?
This is, so this is like any provider visits.
Any.
Yeah, in outpatient
That's right.
settings.
And severe mental illness is like psychotic illnesses, is that what you, how you defined it, or what were you?
So which one?
No,
This one?
just your population here.
Mhm.
You said severe mental illness, so these are individuals who reported having history of psychotic illnesses, or what went
So
into?
basically, like I used 2 survey questions. I think the first one is like I forgot the
PHQ.
PHQ, and then the second is like K6 psychologist like distress.
Oh,
Oh,
Kessler,
so-
Sticks or something.
Right.
Stress and depression related,
Right.
yeah.
Basically,
So dementia is not included.
dementia was not
Dementia
included.
won't be.
Mhm,
Psychosis also not.
mhm,
Yeah, it's.
I think that's why.
mhm.
If dementia was included, that it would definitely be higher.
But the depression is interesting. So is it because of the commercial side, they cover more on the depression and those related services better?
I think.
Mhm.
So we are still like examining the results,
Mhm.
but that may be one possibility because after 65, healthcare utilization for mental health services decreased, right? So that this population may not able to receive necessary care timely, so that probably they may be using like ER as like regular source of care. So that this is like our hypothesis, but we are still trying to examine further. So as I mentioned in the previous slides, so after 65, like mental health services decreased, but ER use increased. So this may suggest that people like with serious mental illness experience limited access to mental health services, and this may be driven by limited access to mental health services in the Medicare program. So I have some other studies that examine the effect of Medicare coverage, and then the first study, I compare the effect of Medicare coverage between immigrants and US-born residents. And in this study, I found that Medicare coverage decreased total and out-of-pocket spending in both population, but for other outcomes, immigrants receive like more beneficial impacts. More specifically, Medicare coverage increased the use of high-value care and self-reported outcomes, especially for immigrants. And then this result suggests that Medicare coverage produce greater benefits to immigrants because immigrants, I think, like often lack health insurance coverage or have limited health insurance coverage.
You
right?
shouldn't show this to Republicans.
We need to work out better language. I was thinking that we just need to change the language a little bit.
Yeah, so probably this results suggesting that like Medicare coverage can contribute to like decreasing like health disparity. And then the last paper that I want to show is like the effects of Medicare coverage on like current conditions. So we thought, as you mentioned, that there may be like pent-up demand, right? So I examined whether after 65, there are some changes in diagnosis of like current conditions. So 19 current conditions. But we found that there are small or no changes before after 65.
I think actually the rumor I mentioned in the beginning is more on the low value care, elective surgeries. So there are a lot of things that they are elective, which they can control the timing of the process. I think a lot of conditions that they have, I think as soon as they have it, they need to do something about it, as long as they can afford it. Yeah. I think, I don't know, yeah. Yeah.
I mean, it makes sense,
yeah.
there wouldn't be to me, it would
Yeah.
make sense, there's no pent-up demand for, say, chronic disease, because, and if we were to see it, I would expect to see something like that in maybe people with very mild disease, because if you have a disease, you're gonna go get care. It's the stuff where there is no actual symptomatic impact on your life that you might reserve for another day. Like toothache is a great one, where like why is dental care so, well, not just expensive, but so difficult for the poor to deal with? Is you can't ignore tooth pain for that long. You have to go get it, you have to go take it, have it taken care of. So I imagine with a lot of these chronic diseases too, that if you have symptoms, you have to go get it taken care of. You can't wait for Medicare. But it would be interesting to look at, maybe, I don't know if you have access to the data, but because you were limiting some of your analyses to specific low value care services. But if you considered some of these other low value care services that are deferrable, but maybe Medicare is smart and they've already figured out what those services are and disincentivize you to know. Otherwise,
Maybe pessimistic about.
Anyway, it's interesting.
I think Medicare is smart, but yeah, there are a lot of folks on the other side of the world who can utilize and gain the system. Yeah.
I beg to disagree. I don't know that Medicare is all that smart.
If Medicare is smart, okay. The voice of God or Mo.
Just Mo, no, not God.
In this room, it's like
Oh,
the
yeah.
voice comes from above. So, sorry, I'll let you.
So to summarize what we found and what I saw in the literature is that Medicare coverage improve access to care, healthcare utilization, health status, right? And then Medicare coverage decrease the financial burden of care. And in my study, I found that Medicare coverage improve financial security and improve food security. Also, in the previous study, in the previous slide, as I mentioned, the Medicare coverage, the benefit was greater among immigrants rather than US born residents. So probably providing Medicare coverage can decrease like health disparity. But so basically I think Medicare program is a great thing, right? Improving healthcare access, health outcomes, and decreasing health disparity. But there are some rooms that we can work on to improve the Medicare program. So the first one is, as I mentioned, the Medicare program is not designed based on value. So policymakers think about like how to improve the design. So that's to increase the use of high value care and decrease the use of like low value care. And then, as I mentioned, in the context of mental health care utilization, still Medicare may not provide like access to essential health services. So I think mental health can be one area, but there may be some other area that we need to work on, right? So probably some other people can work on this thing to figure out which area CMS or like policymakers need to improve. So I think that's all for today's talk. And these are, so I just wanted to show the 3 papers that I mentioned in the talk. And if you want to see other papers, I'm happy to like share later. And thank you. That's all for today's talk. And I think we don't have enough time to talk about my other research in the context of like